All right, we'll start the recording and I'll pull up my share screen one and then go to the presentation. So let's just start with some sort of ovarian unknowns and just sort of present them as you might walk through them. Um, I used these with my residents a while back and they seem to have some fun with them. So this obviously is a solid type tumor. The patient is in her late 40s and early 50s. Um, and there's sort of two components. You can see one here that's more fibrotic and one here that's got a bit more glandular and maybe stromal elements to it. So we'll look first at this more fibrotic area over here. And I think as you see as we go through this, we've got some more solid areas like this and glands. And then a few areas where you get a little bit of stroma around these areas. So what would you be thinking with this kind of an area, Dr. Desalu? What is your initial response to this kind of an appearance?
Where is the site?
This is ovary.
Okay. Adenofibroma.
Yeah, so it's in that adenofibroma category. You've got glands and stroma. And do you want to venture as to what type of adenofibroma, what epithelial type we're dealing with here, where you've got glands and more solid type stuff?
Brainer tumor?
Endometrioid.
Brain.
Yeah.
Yeah.
Mhm.
Yeah. So it looks like it's going to be endometrioid. So that's a helpful kind of first stage to think of that. And then let's look at this more cellular area over here and see where this may take us. As you can see here, we've got more glands, more of this loose stroma, maybe a little bit more in terms of irregularity to some of the glands, a little bit closer spacing, maybe not overwhelming. So I hope that Vinita will agree with me on this, but I thought this, given our endometrioid background that we had on the other area, I thought this started to push us towards a borderline endometrioid adenofibroma, where our glandular structures were becoming a little bit more complex, a little bit more closely spaced, more approaching kind of the endometrial hyperplasia type of pattern that we might associate with a further proliferative process. Not a high degree of atypia, but still, some evidence of proliferation. We can look at this other piece up here, which has more of this more proliferative pattern area and a fairly similar appearance. I think borderline endometrioid adenofibroma is a relatively uncommon lesion. It's not a really hard lesion, I don't think, to figure out. But because we don't see very many of these sorts of things, sometimes it can be a little bit perplexing, and we can be thinking about, other kinds of things in the differential, like carcinomas or Brenner tumors or other sorts of things, depending on how much solid material is in the sample. So comments or questions?
So I'm going to make a couple of comments. I agree with you that for me also, I would call this a borderline endometrioid tumor. Just, I noticed that there were small foci here and there that seemed to suggest cribriforming, but a minor amount of cribriforming is allowed for borderline adenofibromas. I just wanted to flag that because for endometrioid atypical endometrial hyperplasia were particularly sensitive to the cribriform areas. But here you're just seeing, they seem to be intraluminal cribriforming as opposed to anything more than that. So I think this is still borderline endometrioid. The two criteria that would make this into carcinoma arising is that if we saw infiltrative tumor that was greater than 5 millimeters or confluent epithelial growth, neither of which we're seeing in this case. If you miss a small bit of carcinoma in such a lesion, it's probably clinically irrelevant because the outcome for stage 1 borderline endometrioid tumor and stage 1 sort of carcinoma, endometrioid carcinoma of the ovary is essentially the same. 95% 5-year survival, to the extent that, considering the relative sort of paucity of these cases, we just don't even have enough data to compare the two.
The other thing I think is important to comment here is the sampling issue. So, if you just had sampled this area, for example, of your lesion, you might not have come up with a borderline categorization, whereas, having this component easily represented helps you to make that diagnosis. So you do want to make sure that you sample these sorts of things. And these areas don't look terribly different, I think, macroscopically. So I think you might have considered them as possibly similar areas.
Yeah, I agree.
Okay, well, let's go on to another case, and I'm going to pick this one down here. So I think this is an interesting case. Again, we're in the ovary, and you can see that we have nesting of this lesion, sort of nodularity, no evidence of surface involvement here. And then as we look at this lesion, we see that it's confluent epithelium, some clearing of some of the cytoplasm in some areas. And I think you can see some prominent cytoplasmic membranes here in areas. Sort of ovoid nuclei, maybe a few dyskeratotic or apoptotic cells in the mix. And a sort of neoplastic or malignant pattern of epithelium. So what would be your differential for this type of lesion, Dr. Zuditu? Can you unmute yourself, Zuditu, and give us your thoughts?
Did we lose?
Let's see. Have we got her? Oh, I guess she's not there.
Yeah.
Can I try?
Yeah, please.
Malignant Brenner, clear sarcoma, clear carcinoma, and clear variant of papillary serous carcinoma.
Very good. So a malignant Brenner tumor, clear cell carcinoma, and what was the other one you mentioned?
Clear variant of serous carcinoma.
Oh, that's right. So a tumor in the SET category, the serous clear cell pseudoendometrioid transitional type of lesions that are P53 mutated. And I think that's a perfect differential for this type of lesion. The kicker here is that as we worked this patient up, we discovered that she had a history of invasive transitional cell carcinoma. So in reality, this represented a true metastasis from her transitional cell neoplasm in the bladder. So this is a true transitional cell carcinoma in the ovary, although it's not primary, it's a metastatic lesion. But I think it illustrates that point that this morphology, this transitional-like morphology or clear cell pattern, can be seen in a variety of tumors, and that includes the occasional, very rare metastatic lesion that you can occasionally uncover in the ovary. Of course, as you will experience, the metastatic tumors in the ovary are not uncommon, and they can have a variety of morphologic patterns that very closely sometimes mimic the other primary tumors that we see in the ovary. Okay, Zuditu's coming back in. So this was a interesting case from that standpoint, very unusual development. I think things that might have helped you to clue us in were the lack of surface involvement. And I think on some of the other sections, there was kind of good angiolymphatic type of involvement. I don't know if this is one of those areas or not, but there was that suggestion that there may have been some angiolymphatic involvement as well.
I think, I guess two other points or questions. One, the fact that there is residual ovarian stroma, that also makes me suspect a possible metastases. And it looks like, just because the ovarian stroma, the outline of the section, it seems to me that these might not have been very large. So my question was it by any chance bilateral?
I don't remember, Vinita, if it was or not, but you're right. More frequently, you would suspect bilateral metastases. Yeah.
Very nice piece.
Okay, so as long as we're on that. Oh, yes, go ahead.
Is there any chance that this patient has both bladder and ovarian tumors at the same time with no metastasis?
Well, that's an interesting question. I think that would be much less common than metastasis. If they were presenting synchronously, you might be a little bit difficult to ascertain. I think in general, we try to follow the rule of take the most likely course. The most likely etiology is that they're from the same lesion. So I think you'd have to have pretty strong evidence in some manner or another that they were separate and independent primary lesions with similar histologies. Either some drastically different molecular phenotype or something that would make more sense.
Right. I agree there. Like, if your TCC in the bladder was TIS, non-invasive, then you might think about it. I would imagine that in this case, the patient had myoinvasive carcinoma. So the bladder carcinoma was slightly more advanced stage and possibly also had metastases elsewhere, although isolated ovarian metastases is not uncommon in a variety of tumors. So you always have to think about it.
Okay, let me pick this case as sort of a next discussion point. This is a patient. This is not a diagnostic challenge per se. The patient had a previously detected high-grade serous ovarian cancer, but this patient had then undergone, I think, 3 or 4 courses of neoadjuvant therapy, and they came back to do a second look debulking procedure. And this tissue, which I believe, I don't know if it was omental or adnexal tissue was removed in conjunction with that procedure. And as you can see, you have multiple nodules of tissue with a very hyaline pink appearance. And then at higher magnification, we see this a mixture of kind of fibrotic, almost smooth muscle type tissue, lots of neovascularization around this fibrotic scarred down tissue. And then we have some areas like this where we've got more cellular, more ovarian type stromal type tissue. And then, as you probably saw, I had highlighted a couple of areas with the presence of these wonderful marking dots. And we see that here we have a few admixed, very atypical cells with pleomorphic nuclei, some necrotic debris, and so forth. This is an opportunity to kind of review the sort of histologic changes that you may see after treatment in these cases. And obviously, detection of residual disease has some prognostic value and in that setting, but can be very confounded by the chemotherapy effect. So to some degree, the nuclear atypia, the prominent nucleoli, the vacuolization of some of these cells, along with these necrotic debris and these various islands, is largely the treatment effect on this tumor. In some cases, you may have this treatment-affected tumor surrounded by foamy histiocytes or even more solid eosinophilic histiocytes that can be difficult to distinguish from tumor. So, for example, here we have a lot of histiocytes, some multinucleate cells, calcific debris, and sometimes these multinucleate cells can look a little bit on the atypical side, and you may be confused. And so that's why I wanted to show this example to sort of highlight kind of the difference here between this more pure histiocytic response here with the occasional cells that may be residual tumor, like here, or maybe here and here with an atypical mitosis, and then the more clearly residual tumor that we have over here in the more highlighted area where we've got actual, glandular architecture and apoptotic necrotic cells in the lumen. So that's just an example of post-treatment for high-grade serous carcinoma and some of the kinds of changes that you'll see with that. Any comments or questions?
Yeah, I think that's really good. It's really good to highlight the changes that can be seen. Actually, I have a case I'm working on right now. Another thing that I sometimes see is clear cell change, and sometimes it can be mistaken for clear cell carcinoma even. So it's really important just to know that some of those cytologic changes and morphologic changes that you can see with the post-therapy, post-treatment. So that's really a good point to highlight.
Thank you, Kenny. All right, well, let's go on to another case. This was a case where I sort of tripped up a little bit. I got a frozen section biopsy from this patient, and it looked like well, actually, let me go to the area that I think I had on frozen section. It was something sort of like this, with kind of high-grade nuclei. And I hadn't checked the patient's age, and I said, "Oh, I think this could be, high-grade serous carcinoma." And then they said, "Well, she's 35 years old, and her AFP is, 5,000." And I said, "Oh, well, in that case, this is probably not serous carcinoma." But it is certainly reflective of a malignancy. So yeah, we had a few areas that kind of looked like this on our frozen section, glandular tissue and so forth. However, even here, if you have the clue that there are elevated serum tumor markers, these eosinophilic droplets probably would clue you in to be thinking of a germ cell tumor and most likely at least some element of yolk sac tumor. When we finally got the rest of the specimen, as you'll see here, we did have a few other areas that looked more like reasonable proximities of yolk sac tumor with these sort of intermediate grade nuclei lining some polycystic spaces. Nothing that I would call a classic Schiller-Duval body necessarily, although maybe a few areas that are sort of tending in that direction. And then the bulk of the tumor was, as you see here, this much more diffuse islands and irregular cords of tumor cells with slightly higher grade nuclei, less cytoplasm, and a smattering of intervening small dark cells that would correspond to tumor infiltrating lymphocytes. So we rendered a diagnosis ultimately on this case of mixed germ cell tumor with dysgerminoma, areas of yolk sac tumor, broad areas of necrosis, and so forth. And they appropriately staged the tumor, the patient, so that she could get appropriate therapy. So this again, I think, underscores the value for thorough sampling. And then certainly at the frozen section, the time of frozen section, being aware, if possible, of marker status and age of the patient, lest you rush forward to calling something a common epithelial tumor that is actually a germ cell neoplasm. Comments or questions on that case?
Case, I would actually say that I would have gone down the tubes on this one a little bit too, because 35 is sort of on the older
Yes, it is.
of germ cell tumor, and the lower edge of serous carcinoma, especially in patients with sort of genetic predisposition. So if I had the first section, I think I might have done exactly what you did. So you're right, it's good. It's important to know the clinical setting before sort of making the diagnosis. Very nice case.
Yeah, I totally agree.
All right, well, let's keep going. We've got some good discussion going on. This was another very interesting learning case. This is a younger patient who's in her, I think, mid to late 20s with a unilateral ovarian mass. And as you can see at low magnification here, it's got a sort of a combination of solid and sort of sieve-like or slit-like spaces in some areas, a little bit of heterogeneous distribution in the tissues. Coming into sort of higher magnification, you can see that we have some sort of, I don't know, follicle-like structures here with, abundant clear fluid, fairly bland surrounding tissues. And then this very interesting combination of sort of a busy stroma and sort of slit-like tubular pattern interlacing here in the remainder of the tissue. So what would be your thoughts thinking about this in a younger patient as we've described?
Sex cord tumor?
Very good, very good. So you're thinking of sex cord type tumor? And what kinds of tumors would you be considering?
Sertoli type,
All right. Sertoli,
Leydig.
Sertoli only or Sertoli lytic tumor? Uh,
It seems to have a combination of Sertoli and
okay, so
granulosa. Yeah.
yeah, so possible combination with that. Kind of looking at this pattern, is there anything else distinctive here that sort of bothers anyone with this sort of combination slit-like spaces and kind of low cuboidal type pattern?
I guess I would also think about mesonephric.
Yeah, I think that's that sort of consideration, or maybe even a fatwa or something like that comes into the consideration with this sort of a pattern, as we see here. Well, this tumor was nicely positive with inhibin, so it does fall into the sex cord stromal category. But we were very impressed with this, the extent of this pattern, and thought that this probably represented a retiform Sertoli lytic tumor, given the extent and pattern of these very slit-like spaces and angular branches within this structure. We had difficulty actually identifying the lytic component, and I don't remember where we ultimately found some, but I think there were some in either in this block or in another block that came out a little bit more strongly with the MART1 stain than with inhibin. So what do you know about what do people think about this as a retiform type Sertoli lytic tumor? Does anybody agree with me?
Yes.
Thank you, Suditu. How about you, Kenny? What do you think?
I agree with you, but I have to confess that I've stopped. I generally just put it as a description in the note. I no longer specifically subtype it as retiform or not. I mean, it's certainly in these areas that seems like the right diagnosis, but I guess I don't really. I use it as a descriptive label rather than a subtype.
So tell me your reasoning and thoughts behind that. Help me to learn.
Don't know that why. I think it's just how my teachers did it. So I actually don't have a good answer for that.
Okay. Because I sort of grew up with Robin Young showing these cases in our conferences and going, our study follow-up is that these retiform tumors don't do very well compared to other Sertoli lytic tumors. So I was of the notion that if you're going to subtype, a tumor and it has retiform architecture, that's a potentially significant predictor of people's outcome with this tumor.
Yeah, I always was taught that too, but I guess I would kind of split the difference. I would say, because I mean, I think if I remember correctly, most of these ones with retiform pattern either fall into the moderately differentiated or poorly different. So I would top line it as, circulated cell tumor or moderately differentiated and with the retiform pattern. That's probably how I would go. Okay. But I agree. I mean, I always thought it is important to, point out this. And this seems pretty extensive. I've never seen this. I mean, I guess this is one block, I know, but was it how much did the tumor look like this?
It was almost all like this, and I would agree. I've only seen a few cases in my clinical practice, and they usually have just, maybe 10% or a bit more of the tumor that has this kind of a pattern, which is part of what makes this, I think, a very challenging case because it's so extensive and makes you think more like mesonephric or fatwa or something of that sort. Okay, well, that's an interesting discussion, and obviously shows that we have varying styles and patterns. Hopefully there's no one absolutely right way, but certainly as long as we're trying to communicate what we see and what we think it may have implications for, that should help the patient. Okay, let's come down here. All right, this is again an adnexal tumor. This is a patient who had some peritoneal spread of disease and was treated, but with poor response. And so they came back and did more surgery on this patient and removed the primary mass. And this is a representative section of the lesion. It seemed to be more adnexal than primary ovarian based. But at this stage of sampling that we got it was a little bit difficult to tell. So we have, as you can see, a lot of epithelial structures, very blue, some sort of angulated glands, closely spaced, no significant stromal element to it here. And the glands have fairly tall epithelial cells, active mitotic activity, a little bit of necrosis. And then in addition, we have this other morphologic pattern over here where, some of the glands are smaller, a little bit less well-defined. A little bit of sort of, myxoid background tissue, some single file cells, maybe even a little bit of sort of stromal transition here in some of these areas. So what kind of workup would you do for this type of a tumor? What stains would you want to know about for this case? Especially given the fact that I've said that it didn't respond to initial rounds of treatment, which they presumed was for serous carcinoma.
So I'm sorry. So is this a post-chemo specimen? She received
Yes.
chemo.
Yeah, she had failed an initial round of therapy. And I don't remember. I don't remember. This is an outside case that came to us, and I don't remember for sure if they had done TP53 staining on the initial sample or not. But this case turned out to be TP53 negative.
So did you do? I mean, how old is she again?
I think she was 50.
Right, one of those ages that doesn't help you.
Doesn't help you. No.
Is this hyalinized area, is it part of the tumor or
Yes.
possible chemo response?
Well, I suppose that some of these hyaline serpiginous areas could be a degree of tumor response to therapy. That's a good observation. So I think this is a little bit confusing because I think if I were to suspect what's going on here is I think we have a degree of kind of de-differentiation occurring with these more poorly differentiated areas. Whereas this larger glandular area and that area that I went to first over here probably represents the bulk of the tumor in its sort of initial phenotype, if you will, is this kind of a pattern. So this is a tumor. Go ahead.
So you were thinking of dedifferentiated carcinoma?
Well, that was a consideration. Was this an endometrioid tumor that was dedifferentiating? But although this was PAX8 positive, it was negative for any hormone markers. So ER/PR did not stain, and it was not TP53 mutated.
I guess it's not classic, but I mean, I guess I would also consider mesonephric.
Yeah, that's exactly where we ended up, because it did stain with GATA3 and it had a little bit of TTF1 in it. And so we presumed that what we were dealing with was a mesonephric carcinoma that had initially masqueraded as either a serous or an endometrioid tumor and was non-responsive on that basis. And then whatever was going on here represented some sort of molecular progression or degree of dedifferentiation, if you will, in transitioning from the more typical large glandular component to a more infiltrated small gland and single file cell pattern. So these mesonephric and mesonephric-like cancers, I think, are a growing area of concern and potential pitfall for pathologists who don't see a lot of GYN cases because, well, even in very busy practices, you see them relatively rarely. So your index of suspicion has to be high to suspect anything that's, PAX8 positive but hormone negative, with any kind of, good glandular differentiation as possibly having this mesonephric or mesonephric-like phenotype. Other experiences or thoughts on this group of tumors?
I mean, I think they're so rare. I think I've only seen a handful, and you're right. It seems it's the immunohistochemistry that takes you in that direction more than anything else. Receptor negative. I mean, if this was endometrioid, it's moderately differentiated. It should be ER positive. So you just have to think about something else, and then of course the GATA TTF take you in that direction. I just wanted to make one other point with respect to the previous tumor when we were talking about the retiform pattern. Retiform pattern is more associated with Dicer.
That's right.
Yeah. Syndrome. So just throwing that out there.
Yeah. Good point.
Yeah, this is a really interesting case. I haven't seen too many, but every case that I've seen, it's always been your first thought is endometrioid because you always think of more common things. So it's one of those tumors that can really masquerade as endometrioid. And like you pointed out, I mean, I think the hormone receptor being negative is a big tip off that can be helpful. And sometimes you kind of go back in retrospect and you start to see, okay, maybe there are some kind of more tubular structures that have some eosinophilic material in the lumen, and you kind of start to see, okay, well, maybe, but I feel like it's always a retrospect, at least for me, kind of a pickup.
Yeah, I think I've had a few cases where I start looking at the pattern and I go, oh, I think this could be mesonephric, and it's like you say, you have some of the smaller glands, but the other thing that seems to be different from endometrioid is you don't have the really big glands. These tend to be sort of this medium size pattern, fairly tight and not wide open lumens for the most part. And that pattern, I think, may be a little bit suggestive, at least in my brain, that seems to lead me down that road a little ways. All right, well, let's shift gears to a different disorder. This is a large ovary in a patient who was, I believe, 30 years old or something in that ballpark, and presented not with acute abdominal pain or torsion sort of symptoms, but with this mass lesion in the pelvis, and had the ovary removed because it was enlarged. I think it was about 15 centimeters, and they were concerned about neoplasia, so they sent it for frozen section. So this is actually, I think, the frozen section slide that we had on this particular case. So anybody want to approach what they think the differential might be in this sort of a setting? Zudito, are you on? Do you want to give us your thoughts on what you would do with something that looks like this on frozen section?
Stromal edema or stromal
Yeah, very good. Yeah, very good. Stromal edema. So why do you think that? And how would you rule out the other possible considerations? So one of the things that I usually look for in that diagnosis,
it looks like a maintained ovarian stroma with
yeah, so you
can you
maintain
hear me?
some degree of ovarian stroma.
My network is not stable.
Okay. So one thing I look for is some preservation of normal architecture near the surface. And I didn't really have that here. There's just maybe a little bit of suggestion that you've got a normal surface here, but I couldn't find any, primary follicles. I couldn't find any oocytes. And so I was really struggling with this a little bit and wondered about some of the other things that you might consider, like stromal tumors or sclerosing stromal tumor, for example, can have very edematous areas, or possibly, something else going on. However, when we got the rest of the sections back, indeed, this was a massive edema of the ovary and not anything neoplastic. And we hadn't given them any need to go do staging or remove further organs. So fortunately, we didn't have any patient mishap from being a little tardy on recognizing this at frozen section. Anyone else have experience with this entity that they want to share?
Agree with you. So did you call it unfrozen?
I said most likely ovarian edema, massive ovarian edema. I said it doesn't really look like a stromal neoplasm. I'd favor it, maybe massive ovarian edema. And that seemed sort of clinically fit for what their concern was, and she looked clean otherwise, and so they didn't do anything more.
So I thought I saw some pink cells, like almost.
This stuff.
Yeah. What did you think of that?
Yeah, so this is what gave us pause on frozen. Could this be a stromal neoplasm?
Right.
We wondered if these were luteinized cells or something
Right.
of that ilk,
Yeah.
as the most likely explanation for why we were seeing those. And that sort of goes along with one of Dr. Scully's old mantras, which was that you can see luteinized cells in just about any lesion in the ovary.
Yeah. Well, but at the frozen section, it becomes really hard.
Yeah, I think that's a really tough frozen.
That's a tough frozen section. Very tough frozen section for me.
Well, I think frozen sections in the ovary are certainly one of the things that makes gynecologic pathology so challenging, both for those who do it a lot and for those, especially for those who do it much less frequently. So, all right, let's see. I think we've got one or two more cases we can do here. I'm trying to see which one here will be the next best one here. So yes, this is a good sort of correlate to the one that we've just done. And I don't remember the age on this patient. But as you can see, we have this multi-nodular pattern. We have some large, I don't know, follicle-like spaces or cystic spaces. We've got areas that have this sort of microglandular-like appearance with lots of intervening mucoid tissue or mucinous-like tissue. But we don't have a classic epithelial appearance. We rather have sort of a more stromal appearance to some of these areas with lots of small cystic spaces. And even around these more mucoid areas, it's more the cells are more arranged to sort of streaming around it rather than sort of lining up to produce it. So it doesn't look to me like it has an epithelial pattern, although it's got this microcystic and mucinous backdrop. So what categories should we be thinking about for this? Dr. Desalu, any thoughts?
I categorize this as a stromal tumor, possibly signet ring.
What was the last part? Possibly what?
Signet ring stromal tumor.
Sclerosing stromal tumor. Okay, yeah. So puts it in the stromal tumor category.
Signet ring, yeah.
Sig
Signet ring type.
Oh, signet ring type. Okay, very good. Okay. That I don't have any. I don't think I've ever seen a good example of that. I don't think this actually fits into that category, but that's certainly in the differential. When you see these kinds of very sclerotic bands, I mean, this is certainly one feature that we see often in conventional stromal tumors, fibromas, fibrothecomas, and so forth. And this is a stromal neoplasm. But I believe this fits best in the so-called microcystic type of stromal tumor, where this pattern is very characteristic of the features. Does anybody want to comment on the immunohistochemistry for this lesion? Because I know there's some distinctive immunohistochemistry things on this, but I can't remember them right off the top of my head.
Well, I know that they're CTNNB positive. I'm
yes.
That's what it is. I'm not sure that I'm not aware of the distinctive immunohistochemistry.
Well, I think it is. You're right. It is a CTNNB1 mutated lesion, so it's positive with beta-catenin, and it's the lesions in the ovary that are beta-catenin positive are quite limited in number, and nothing else that really looks like this. So that's the very helpful immunohistochemistry here is the CTNN1B or beta-catenin. Okay, so just for contrast, let me show you one other case here, which not really a diagnostic problem, but I think highlights what we would see with a lot of signet ring cells in the stroma. So this is a very classic Krukenberg tumor, where here you see these signet ring cells all scattered through the stroma with somewhat of a microcystic pattern in terms of the mucin separating collagen fibers and so forth. But obviously, in this case, occasionally having these condensed clusters of more classic epithelial cells, along with the floating through the mucin kinds of signet ring cell tumors or signet ring cells from the neoplasm. This was a case of a classic gastric carcinoma that had metastasized to both ovaries, and hence was a classic Krukenberg tumor. Now, I'm not aware if it's been done. Obviously, now we are moving towards kind of the molecular classification in more and more tumor sites. And many of these signet ring cell carcinomas in the stomach are associated with CDH1 germline mutations or spontaneous CDH1 mutations, where they may also be associated with breast carcinomas and so forth. But I don't know if any study has been done as to whether or not the Krukenberg tumors in the ovary are in that category of either germline or spontaneous tumors. Either of you aware of any study to that effect?
I'm not aware.
Yeah,
I'm not.
thing to have somebody sort out and see if there's any predictive value in terms of metastatic potential relative to one or the other kinds of statuses.
I just wanted to mention, going back to the microcystic stromal tumor, one of the characteristic things, I guess, is that they're unlike other stromal tumors you would expect to be inhibit and calretinin. They can typically be either negative or just weak, but they are positive for FOXL2 and SF1, WT1, kind of, putting it into that stromal tumor category. But that is something that's a little bit unique about these tumors.
Great, thank you, Kenny. So the last couple of minutes, I just wanted to revisit where we stand with regard to our progress on the self-study materials. And Dr. Desalu, Dr. Parte, Zutito, when she comes back on, I would hope that you would continue to put some effort into those self-study materials at open-pathology.org, because I think you'll get much more out of our live sessions if you have spent time there. And I don't know if you've encountered problems or delays or frustrations in that effort, but I certainly would be welcome your comments or frustrations or whatever else could help you to get through those. As best we can tell, no one has made it to Module 3 yet, and that's where most of the advanced information is on some of the more esoteric topics like we've been talking about today will be found. Dr. Desalu, what is your experience with those self-study materials? Anything we should know?
You mean that are posted on this module?
Yes. It's open at the website that I just typed in. Yeah. We
on
wanted
my
to.
side, actually, there is no frustration at all. There is no, rather, we fear that when we are lagging behind and if we are not in a good pace that you expect us, you may be, disappointed. We think that you'll be disappointed if we are not in a good race. Otherwise, we are enjoying, it's very interesting, and we are grateful of you to present all these materials. The problem is that we have overlapping activities in our department. We are not working in subspecialty. We have to do everything. There are other commitments. That is the main reason. Otherwise, sorry for that. You are not. Sorry for your expectation.
Well, my expectation, or it's really my aspiration, is that you can become more proficient with this material, and that we have organized it and presented in a way that is at a doable pace for you. We tried to break things up into smaller chunks, smaller units, so that even if you only had 15 minutes a day or an hour on the weekend or something, that you could make a progress with a few parts of the module and eventually make it through to reach that eventual stage. And So, if you're not having problems with the module, it's just the time and that sort of issue, then I feel better. But I would encourage you to keep moving through. And as you encounter issues or problems, I mean, that's where you can come back to your mentors, share questions that may have arisen that you didn't fully understand from the modules, and bring those back to this discussion, or just put them in the WeChat so that we can participate and help you resolve those early, so they don't become issues down the road.
Thank you so much for we have you really. We loved the participation, especially this time. You are a very important person indeed. I have some cases like the ones that I have presented last week. I'm going through, and the drawback here is the facilities, the ancillary tests are we're running out of that. That doesn't support our diagnosis, especially immunohistochemistry. Otherwise, we're encouraged. One comment I need to raise in this module is when we answer the questions. Sometimes the choices, 2 or 3 answers may be there. If we answer 2, the whole code, the whole answer will be disqualified. Is that?
Yeah, so there are 2 types of questions. There are what we call multiple choice, where only one answer is correct. Those have round circles. And then there are multiple possible answers. Those have square boxes. And you're right, if you don't get all the right boxes, then you have to go back and do them. But that's most of the questions after each section those are non-credit, not graded. The only things that are graded for passing the module are the midterm and the final. And I think most of those are multiple choice, just single answer is correct rather than multiple answers. I may be wrong on that, but we have given you the opportunity to retake the test if you need to try to get it right and reach that passing threshold. But again, having said that, the passing threshold is not, it's not 95%. It's I think 70% or something like that to be able to get that pat on the back for you.
Thank you.
I think the multiple selection questions issue has come up many times, both in this setting and also, the performance improvement program for the CAP. So we've actually, for the CAP, we no longer allow multiple answer questions. It seems to unsettle people. So that maybe, when we get to phase 2.0 or 3.0, maybe we can think about that a little bit more.
Yeah, that's a good point. And I think as we make more modules, I mean, right now we have a module on breast pathology that's nearing completion. We have some lung modules that are nearing completion. We're getting some modules on head and neck pathology. So we're going to make this, the website and the courses, a very robust training center with these kinds of things. And so we want to learn as much as we can from the GYN modules so that we don't repeat the same mistakes. We make it more user-friendly for all the people that are going to use all of the other materials.
Sorry, I was having an interruption with network, but
yes,
I would like to, yeah, I was having a lot of interruption with our network. But I would like to say thank you for this wonderful educational opportunity. I found all the modules are very well or excellently prepared, and it was so helpful for our current practice, both teaching and as well as the clinical practice. And also the questions are very tricky, but for me, it allowed me to go back and check what I missed. And I liked them, but sometimes it could be a bit annoying to have an X mark, but they are actually, they can be a guide to go back and check what I missed during the session. And the lack of progress is mainly because of, in my side, as I already mentioned on the WhatsApp group, this was our new year. September is our new year. Our children start their education at this time. We have a lot of clinical works and so on. That's why we are so crowded. That's why we lag with the progress. And Aisha is not also around here.
Okay.
He's in America. Probably. She'll be back soon.
Okay.
Yeah,
Vinita,
I would like to thank you. Anyways, all the group, Dr. Hassel and Dr. Vinita, thank you. It's an excellent educational material, and we are planning also to invite our other friends, our pathologist colleagues to have the opportunity.
Sounds good.
Do
Yeah.
you have a preference for the type of educational material in the live sessions? Like, Dr. Hassel did a spectacular job today, and we all have to try and live up to him. But is your preference for many cases, as Dr. Hassel went through, because in other sessions, the mentors have presented a single case and covered sort of didactic material also, or do you like a mix of both? You don't have to answer me right now. You can think about it and let us know.
No, a mix is very good. All are, yeah.
Well, we have a couple more sessions at least. So we have November and December. So we'll continue, and then hopefully you guys can.
Yeah, we're learning a lot actually. Thank you.
All right. Well, thanks everyone. Have a good evening.
Bye.
Good afternoon.
Thank you so much. Thank you.
Thank you so much. It was
Okay,
really
bye.
awesome.
Thank you, Ekene.
Bye.